Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this wonderful Monday morning as we watch the temperatures rise into the 60s. That is true happiness. Hey, we have more news related to you today about COVID-19 and breast cancer. You know, we had a conversation last week about it. We're bringing it back with so many questions around it. We have a special conversation today when we're going to talk about a new therapy that could not come at a better time than right now around early stage breast cancer treatment. This therapy is a strong incentive to make sure you keep up with your mammograms. Remember last week we heard that the number of mammograms had gone down and that women had been presenting at a later stage with more advanced breast cancer. Obviously not the right outcome, not the thing we want to see. So today, breast surgical oncologist Dr. Kelsey Larson will explain everything in just a moment. But first, Hawk, how are we doing?
Holding steady. You know, I think over the weekend I was kind of getting a little bit concerned. They were pushing up.
Yeah.
Kind of calmed down now. We still are under 40. I think we got up to like 38 or 39 acute infections over the weekend. 36 acute infections in the hospital right now, with 11 in the ICU and 6 on the ventilator. 36 more in that recovery phase as well. 1 on the ventilator. Hays is holding steady as well. 14 total with 10 acutes and 4 in that recovery phase. So
it is, but you know, we're going to pass, I think today, a fairly somber milestone of 500,000 deaths in COVID-19. When we started this almost a year ago, would you have thought that was going to be true?
No, I mean, we know that COVID-19, I think, was it December or January, was the highest, cause of death in America at that point. Yeah, single cause.
More people that have died now from COVID-19 than in World War I, plus World War II, plus the Vietnam War. Yeah. That is a staggering statistic to me, and I know it's going to be it is still exceeded by the great pandemic of 18 and 19, the influenza pandemic. There are 675,000 deaths or thereabouts, but unfortunately COVID-19 is not over, so reaching past that is not impossible. Hey, before we jump into our discussion today, are there any reporter questions that we need to answer?
Sure. Good morning, Cody Holyoke, Channel 9.
Hey, Cody.
Happy Monday.
Happy Monday.
You kind of talked about the 500,000 deaths, which is, like you said, a staggering milestone. When Dr. Fauci was on TV yesterday, he was also talking about mask wearing, and I get this question quite a bit. If the viewers ask, if we are vaccinating the public, why then might we have to wear masks into 2022, which is something that Dr. Fauci was throwing around. I'm just curious your take on that.
You bet. Well, I think, Cody, if we could get 90% of Americans vaccinated in a short time frame, then we probably wouldn't have to wear masks into 2022. I think the problem is our vaccine rollout is going slower than we hoped. You know, we had talked about April. We thought maybe they would be open up and remove some of the tiering, but it appears now that that's going to be late May or June because of the delay in getting all the vaccine into the marketplace. I know Johnson & Johnson was having some trouble. We're assuming it's going to be approved, and I think all signs point that direction. Let's assume that it is, but they're only going to get 10 million doses out here in the first shipment. We were hoping for 100 million doses. So that change means that our vaccination schedule is going to go along a lot slower, which is why I think the mask wearing is getting pushed further and further out now into 2022, and which is unfortunate. I was looking forward to fall, but it looks like it could be later. Now, there also are variables with that. If we do get more vaccine, that could change. You know, it's now said that about a third of Americans have had COVID-19. And but we got to get to those 2/3 that have not. And remember that we think your immunogenicity will wane over some period of time, and we're not sure how long that is. It may be, let's say it's a year, then people who originally had COVID-19 last summer, by this fall probably will have lost most of the protection from that and are going to need to be vaccinated. In addition, it'll give us a better chance to understand the variants. Remember that even if you've been vaccinated, you can still get COVID-19. We'll talk about that hopefully later this week. The number of our employees, remember we've done about, we've vaccinated 16,000 people on our campus, but a number of them have gotten COVID-19 6 weeks after the vaccination on testing. And so you can still get it. It's just that you're not going to be hospitalized or critically ill. If you can still get it, the fear is you can still spread it. And while there are still so many people who haven't been vaccinated, it means that you can still transmit, and you can still, and then, as we know, people can add to that 500,000 lives.
Yeah, I think that's the important thing to remember. the vaccines are efficacious, and I think efficacy in here that we're talking about, as you had specifically mentioned, is reducing hospitalizations and reducing death. But we know that even some of our employees, and even in the studies, people are still getting COVID-19, at least on testing. How symptomatic are they? Probably less symptomatic. But I think the other thing is the new variants. So the variants we know, I think New York announced their first case of B1351, the variant from South Africa. We'll have to see how that all plays out. We know that genome sequencing is ramping up, so hopefully we'll have better detection modes for that. But hopefully, when we are able to get most of the general population vaccinated, we will be able to reduce the use of mask wearing, for sure.
I think it comes down, really, masks do two things. They protect you, and even more importantly, they say I care about everyone else, because they really help everybody. And I think that's the real genesis of why we're going to have having masks until we get everybody really well vaccinated. And we have a good plan for getting people revaccinated.
Yeah, because I did hear what the Israeli studies, and I think Dr. Fauci even mentioned at one point, it does look like there is a reduction in transmission.
It does.
With full vaccine. Do we really move towards trying to get as many of those first doses of vaccine of Moderna and Pfizer in the arms, and then have to delay that second dose? Really, all those studies do represent, though, that you need that second dose of the Moderna and Pfizer. And if J&J is approved, that looks like a one-dose vaccine right now. That will also help.
It'll be very interesting to see, because J&J is doing follow-up studies now with double vaccination. And it's going to be interesting to see if their data will look like Moderna's and Pfizer's data if they do double vaccination. Here's my bet.
I believe it would.
I think it is too. I think what's going to happen is we're going to find out, and we're seeing that in Israel, right, with some of the data in the young, healthy hospital workers, that where with Pfizer they did one vaccination and they were 85% effective, young people. So that's one thing. But I think we're going to see that to be true with J&J, Pfizer, Moderna. I bet the data's all going to look the same. That with one dose, you're pretty effective. With two doses, you're going to be really effective. So which one do you want? Pretty effective or really effective?
Yeah, because that second dose really helps with the durability, and then you also further boost that specific immune response, that adaptive immune response that occurred with that first vaccine.
Yeah. Okay. My speculation, though. Make sure you don't quote that as fact, Cody.
Okay.
All right. Other questions?
We've got Charlie Keegan here from 41. Good morning,
Hey, Charlie.
everyone.
Good morning.
Hi.
Tomorrow, Channel 41 is going to be doing a special on mental health during this COVID-19 pandemic, and I wanted to just get you guys' quick opinions on what you've noticed with mental health, what advice you have for people coping with everything.
Wow, that is like the hardest question, Hawk, I think. I think people struggle around mental health from isolation, fear, anxiety, depression, and loss. And I think the things that we're seeing around the pandemic have made all of those things true, and it's made them all true simultaneously. And I think that's hard, right? Anxiety over what is happening, fear of what could happen, loss of someone you love, and then isolation, so you can't even be around other people. And I think that combination is just, it's often deadly. And we've seen that in suicide rates. We've seen that in calls to the suicide hotline. We've seen that, reflected in throughout what's happening in our population, in our area, and throughout the country and throughout the world. There's one way out of that, right? The way out of that is to get people vaccinated and to try and keep folks safe. But when you've lost 500,000 people in 1 year, let's say that out loud. In 1 year, we've lost 500,000 people from one disease. We talked about World War I, World War II, and Vietnam. Well, that spans 10 or 15 years, whatever the number. But this is in 1 year, and that's a reason to be depressed.
Yeah, absolutely. And I've seen it in my personal life. We are lucky because we have been able to come into work. We do have some social interaction here, but there are friends. I have a friend who has been unable to do that. Still has a job, but this job required a lot of travel. Has not been doing that. Has really been in the house, almost for the whole year, and it affects him on a daily basis. So I think it affects a lot of people, certainly some degrees more than others, but it truly does affect people on some level. We'd still like to be out at the K or at Arrowhead socializing in that, or with friends and family over the holiday seasons. So it is a very significant part of all of this, not just the physical aspects of COVID, but the mental aspects and emotional aspects for everyone else.
It's really hard. I'm going to introduce again just Kelsey Larson, who's one of our breast surgical oncologists, and say this has got to be rampant in your patient population too. This kind of depression to go along with the concerns around COVID-19. Anything that you want to add to that?
Well, I mean, for our patients, a cancer diagnosis is never an easy time, of course. And so some of the things that we have struggled with and been working really hard on is trying to make sure we're engaging patients' family and ensuring their support system is there, while also maintaining that social distancing, safe environment for the patients as well as for the caregivers. So it's really been a balancing act, trying to support people from both standpoints and keep everyone safe.
All right. Other questions?
Shane with KCTV5 wants to know about your opinions on barriers to older populations and people who don't have internet. They're having to enlist a lot of help. He wants to know if that's a flaw in this system.
It sure can be a flaw, and it depends because so much of what we do depends upon the internet and depends upon having some email or some way to do that. And you're right. I think there are a lot of people who don't have access like that in urban and rural areas. So the answer is you have to have a phone list. For example, I know that we're making calls every day to patients on our phone list, and I forgot the number, but we make sure we use but we clearly make phone calls out to patients to say, do you want to come get the vaccine? So we have a phone scheduling system as well as MyChart and all these other things that are great. What I would also say to many folks out there is that if you have children or other friends who you know are involved, have access, then man, I would try and use that as best you can to leverage it. And then I think counties do a good job. I think health departments and federally qualified health centers, they know how to find people because they do that. Homeless people, people who are in difficult situations, congregate living. And so I think that they do a good job of trying to reach out to areas that others may not. So I think those are all ways we can go about that, Hawk. Anything else?
No, I mean, I would agree with
Yeah.
I think.
Okay. All right. So our topic today is a new radiation treatment to be given in a single dose during surgery to breast cancer patients. So this is amazing stuff. You feel a little like you're watching Star Trek right here. This therapy couldn't have come at a better time than the pandemic because of its many benefits that we're going to cover. And it helps keep patients safer at home and during the COVID community spread. I want you to meet Betty Dickinson, one of our first patients to receive intraoperative radiation therapy, also called IORT.
So I went, not thinking or worried about a thing.
Betty Dickinson and her girlfriends kept their annual Girls' Day mammogram appointment despite the pandemic. She felt safe, but she didn't expect to be singled out for further testing.
They kept checking and then they went back and rechecked and then they told me that they saw something and they wanted to do a different mammogram. Then they did the biopsy, said yes, it was cancer.
Getting her regular screenings paid off. Early detection allowed her to try a new radiation cancer treatment called IORT.
It's really a wonderful benefit to our patients and to offer something so innovative.
And the timing of this new therapy couldn't be better during a pandemic. Dr. Kelsey Larson is a breast surgical oncologist at the University of Kansas Cancer Center.
IORT stands for intraoperative radiation treatment for breast cancer. This is a technique for giving people who are having lumpectomy radiation in a single dose in the operating room at the same time as their surgery, rather than having to come in for multiple visits over several weeks.
Making it safe and more convenient for people like Betty, trying to stay close to home and safe during COVID.
Betty was a great patient that could have this type of treatment because she lives a little ways away from the KU Cancer Center. So she would have to drive quite far in order to receive her treatment.
It's a game changer for patients like Betty who caught her cancer early.
There are so many benefits to IORT for breast cancer. So the recurrence and the survival are just as good as doing a longer course of radiation. And actually the survival is better doing IORT because of some of the side effects that can happen with traditional radiation. In addition, patients who get IORT have improved cosmetic appearance after the surgery.
They removed it, did the radiation. I'm all healed up pretty much, and I think I'm good to go.
Betty took her diagnosis and treatment in stride and was glad to quickly put this behind her.
I had faith in my team, so I didn't really worry too much about it.
Dr. Larson reminds us that screening is key. for better outcomes and better treatment options.
It allows them to have their best cancer care and get back to their life sooner.
All right, Dr. Larson. So Betty's your patient. Talk to us a little bit about intraoperative radiation therapy and what that really means and what you're doing, how's it work, what the heck's going on there?
Yeah, so IORT is a FDA-approved standard of care treatment option. So this is not something that's research or part of a clinical trial. It's a standard of care option. And for select patients, it gives them the ability to get their radiation treatment at the same time as their surgery. So instead of going in for 3 to 6 weeks of daily radiation treatment, they can do all of their treatment at that time of their breast cancer operation.
That is amazing. So you've been a champion here for this, I think. Is that right?
That is right. Yep. This is something I had a lot of experience on in my training. And when I came to KU, I really saw it could be a huge benefit to our patients.
So what do your radiation therapy colleagues think of this?
Well, the radiation oncologists, I think, we're not sure what to think about this when I initially started talking about it, but I actually give them all the credit because they were willing to have the conversation with me about it, and they went above and beyond, going to a couple conferences, learning about it, expanding their skill set and their knowledge base, because without them, we can't bring this here. So really, they were tremendous in terms of bringing this on board.
How long has this been around?
The initial FDA approval was obtained all the way back in 1999.
So it's been, that's 20 years.
A long time,
23
yeah.
Years. Yeah, 20
Yep.
years. Yeah, a long time.
So a very long time.
So does that mean that it's just been a little slow to take off? Why hasn't it taken off a little more rapidly?
It's been a little slow to take off, especially in the Midwest. So for some reason on the coast, East and West Coast, and a little bit in the South, it's been a bit more popular to get up and running. And in the Midwest, it's been a little harder to get in to the system. A lot of it has to do with the organization, the coordination, and the advanced skills that you need in order
Right.
to offer it.
Who else offers it around here?
We are the first in Kansas,
Yeah.
Missouri, Nebraska, and Oklahoma to
Holy
offer
cow.
it. So
Well, we're not gonna be the
several
last.
hours away.
Yeah.
I'm sure not.
And so when you look at the patients, are their outcomes the same as it would be as if they'd had traditional radiation to go along with their surgery?
Yeah, so from a cancer treatment standpoint, the recurrence is actually the same. The survival in some studies is actually a little bit better due to fewer side effects of radiation, although
Okay.
that's a bit of a topic of debate. But the other thing is that there's fewer side effects. So in
Yeah.
terms of the cosmetic outcomes, the appearance, some of the side effects of radiation, those are less with the IORT treatment.
So who's a candidate?
Great candidates for IORT are people who are 45 years of age or older with a ER-positive invasive breast cancer that's small and early stage, and who are going to be having lumpectomy for their surgery. So those are the people who might qualify for IORT.
So why does it have to be 45 and older? What happens when you're younger than 45?
That's the key thing, is we don't actually know. So the trials that were conducted that did this set that as an age cutoff. And so we are going by the standard of care treatment in those trials and through the national guidelines with that age.
So why would it be less effective than just routine or standard radiation therapy? What makes that difference?
It's actually equally effective, but what's interesting is people didn't think that that radiation dose we give in surgery could actually work. And the more studies that are being done, they're thinking that it might be a combination of the radiation itself, as well as a bit of an immune modulatory effect. So they're seeing some changes on a basic science level that
Interesting.
happens in the tumor cavity as well as in these patients with this type of radiation.
Okay. So update us a little bit on cancer screenings. We heard last week that, man, the
Yeah.
numbers are down. Are you seeing the
Yes.
same?
Yep, we are seeing the numbers are down. So for a brief amount of time, we were not doing screening mammograms at the early stages of COVID, just trying to make sure it was a safe environment for our patients to come into. But all of the mammogram centers in the area, including ours, are open and are welcoming patients, and we want you to come in for your screening imaging. We know that screening detects cancer at an earlier stage, and so treatment options like IORT are available if you can detect it early.
Yeah. So we heard that it's like the number of screenings has dropped by 50% or something, which
Yeah.
is just bad. 'Cause
Yes.
I don't think the COVID's curing breast cancer, right?
Not that I've heard.
Yeah.
I'm not sure about that one.
Okay. Maybe vaccination's bad because you're not going to have your breast cancer cured. I'm just kidding,
Yeah.
people. Do not think that that's true. All right. Well, let's jump into questions from our community. What's out there, Jill?
Well, Isaac has a question that's related to the topic. He wonders if radiation has any impact on COVID.
Does radiation have an impact on COVID? What do you think?
I mean, so I think we have to Does it have an
I
impact?
handed that one right over. Did you notice how I didn't have an opinion for that?
No, does it
notice
have
I
an
gave that
impact
right to
on
you?
the virus? I think we understand that radiation, particularly UV radiation, ultraviolet radiation, does have an impact on life forms. I mean, it has an impact on us. It can certainly cause DNA changes that allow for skin cancers to come out. We know that for bacteria and viruses, UV radiation can certainly kill those viruses and bacteria. But as far as, are we talking about COVID-19, the disease? I would think if anything, there would be a detrimental effect, but I think it also depends on what type of radiation are you getting. Is it local radiation? Is it systemic radiation? People get hit with total body irradiation with some cancers like AML before transplant, things of that nature. So, but I don't see it overall having an effect one way or the other. If anything, depending on where the radiation site was too, especially your lungs, if you had it in your chest wall, there could be scarring in the lungs, adding to maybe complications if you get COVID-19. But
Yeah, I would be worried about that immune modulatory effect inside the lung, because we know that pulmonary fibrosis is one of the more common complications of COVID-19. I would be worried about that. But have you guys had that as a conversation at all, Kelly? Should you do radiation when people have acute COVID?
Yeah. So radiation for breast cancer treatment, whether it's IORT or the traditional external radiation, is not something that makes people immunocompromised. So as you said, other types of patients, it may be different, but for breast cancer patients, it's not. So having a fear or worry about COVID is not a reason to shortchange your cancer treatment, because we want to make sure long-term you have the best cancer outcomes.
Okay.
All right, Shanna, she got her COVID shot early in February, and then 2 days later was sick as a dog because she had COVID. She's confused on March 5th. She's supposed to get her second shot. She said she read you're supposed to wait 90 days. Do I go ahead and get the second shot because I've had COVID? And the
That's
other
a great
question that
question.
she had was, maybe I don't need it because the first shot is supposed to be really effective.
Well, you know what, those are great questions, Hawkeye. Let's try and unravel it a little bit. But, you know, there's some stuff that hit over the weekend at the end of last week. Gosh, do people who have had COVID only need one shot and not two shots anyway? Well, what do you think?
Yeah, I mean, the prevailing thought right now is you still need that 2 shots. All of the studies are done with 2 shots. Moderna and Pfizer had EUA, emergency use authorization, based on the 2-shot data. So certainly, if you are getting those vaccines, then you need to get your second dose. Now, we have said if there are unforeseen circumstances and you need to delay it, that's fine. But getting COVID-19 shortly after getting that first dose of vaccine would not be one of those circumstances. If you have a scheduled time to get your second dose, go ahead and get it, regardless of if you've had COVID-19 or not.
You also wonder and I don't know the answer to this, you get the shot and then you get COVID-19. It's almost like together that was your first shot now.
Almost, if it's
And you
close
just
enough.
wonder, you just wonder if maybe that person really does need both shots.
Yeah.
And I don't know if waiting another 2 weeks or another 4 weeks would really make any difference. If they were a little nervous about getting it early in March, maybe they wanted to get it early. I don't think that's going to make a difference in how well the vaccine works.
Yeah, I mean, hopefully you would still boost that adaptive immune response that has occurred with that first vaccine and that close COVID-19 infection. But what I'm going to tell you is, if you are scheduled to get your second dose and you got
get it.
COVID-19 after your first dose, get your second dose.
Yeah.
Unless you have it within 10 days where you need to be isolated and away from people before that second dose. Because if you have it and you're still within that 10 days, we don't want you to go out into public to get that second dose. So.
Okay, so Francis wants to know, what about your advice for him? Because he just tested positive for COVID. Should he wait?
Well, that's a funny one, because people wonder if was that person sick or not. But if they tested positive, you don't really know how long they've had it or how long ago it was. So I'd say, man, let's get that shot going soon.
Yeah, and I don't know if you've tested positive after the first dose or the second dose. Sorry,
He's not had a dose
Yeah,
yet.
he's just wanting to know, now I've tested positive,
Yeah.
should I wait?
No, I mean, there is no minimum time between infection and immunization, but we would have you wait at this point in time until you get to that 10-day isolation point ending, so that you're not out with an active acute infection, spreading it to potential healthcare givers and other people who may be in that vaccination site. And if you don't have symptoms and you tested positive, you have to be waiting 10 days anyways. Anytime you develop symptoms within that 10 days, the clock starts from there, from that first day that you develop symptoms. But after that, after you're out of your isolation period, you can go ahead and get your vaccine.
And that original recommendation of waiting 90 days after your first, if you've had COVID before you would get your vaccination, what do you think about that? When we talked about that before.
You know, I think that was spot on at the time, and we were doing that because there was even less vaccine at that point in time. So we know it happened to some of our colleagues who had COVID-19. They volunteered to delay their dose, but now that is not recommended because there is more supply than there was, although still not optimal. But we really want people to be able to get their scheduled dose and get their second scheduled dose.
Kelly, when you think about having to give chemotherapy to patients who have had cancer, breast cancer, or whatever, do you look at if they are acutely affected with COVID-19, would you go ahead and start their chemotherapy, or would you wait for that acute infection to subside?
Yeah, so for all of the cancer treatments that we're doing right now, chemotherapy, radiation, as well as surgery, patients do need to have a negative COVID test before starting their cancer treatment. And then for things like chemotherapy, where they're getting it frequently over several months, they do have additional testing. And so they would hold or delay a dose of chemotherapy if they are testing positive. So it's very important, especially for our cancer patients, that they're keeping safe and getting the vaccine if they're eligible, or making sure they're social distancing either way.
Right. You know, one of the things I wanted to ask, and I forgot a moment ago, about intraoperative radiation therapy for breast cancer, there still must be side effects. What are they?
The most common side effects are actually quite minimal, and they're related to surgery. So the common side effects are anything that you would see with surgery, which is an infection or seroma, fluid collection. The rates of these side effects are actually no different than the rates that we would have any other surgical side effect.
Okay.
That may be what Megan is asking. I'm not sure, because I was reading and trying to listen, but she wanted to know, and we're going to talk about this at the end of the program too. Should I delay my mammogram because I've seen that some breast cancer screenings, that there's side effects
Absolutely. We do not recommend delaying
with the shot?
With the shot. So the question is about when you get the shot, should you delay your mammogram?
I think they're worried about some of that lymphadenopathy.
Yeah, exactly. So I think, as Dr. Winblad explained to us, within the breast itself, there are no associated changes with the vaccine. So the mammogram is really specifically looking at the breast tissue and the breast itself. And so typically we don't recommend any large delays in getting those mammograms because of the shot. Now, if you wanted to wait a couple days or even a week or two just because you got your shot and you might be a little sore, certainly it's not a problem. But no large delays just because of that.
In fact, we need people to get their mammograms, and it's not self-serving.
Yes.
We don't care where you go to get your mammogram.
No.
Go get your mammogram.
There's lots of mammogram places.
Yeah,
I mean,
they're a great job.
of course, we think we do a wonderful job, but
Right.
get your mammogram wherever you go. That's really important to go and get that screening.
We're KU, St. Luke's, HCA, Olathe, Shawnee Mission, North Kansas City,
Yep.
Liberty. It doesn't matter. Truman, go get your mammogram.
Yes.
Okay, Glenn wants to know, the doctors keep saying that the protection will wane, but what is that based on? There's no data or studies showing that the protection lasts a long time, but are there any studies showing that the protection wanes?
Does protection wane over time, either from COVID-19 or vaccination? I've seen data for 8 months post-vaccination that suggests you still had really good antibody levels. I don't know. I haven't seen anything recently. Maybe you have.
No, I would agree with our viewer. It is based on lack of data, and we do want more data and want more information. And it's not only decrease in immune response, and whether that's antibodies or T cell responses. Remember, you still do have some memory function of both of those types of cells. But it's also based on the new variants, or any new variants which may arise, which may cause maybe not the most optimal immune response to occur even after you've had your full vaccination series. So, I would agree with our viewer. It is based on lack of data, but we are getting more and more information. And we just anticipate, based on other common cough and cold coronaviruses, which we know you can be reinfected with within 6, 9, 12 months of being infected with that same virus in the past. We know also about the mutations that occur in every replication cycle of this virus and the variants that it can occur. So it's based on theory, but also on what we've seen in the common cough and cold coronaviruses that we are making that assessment. Hopefully we will have more data, but I think a lot of people are still believing that there will be at least probably some sort of yearly booster based on those types of things.
Yeah, I think that we're going to have a yearly booster. I think that'll change enough, be a little like influenza. We'll still need to do that. It'd be great if we don't.
Yeah.
Don't expect that to be the case, however.
Craig wants to know if you're familiar with the Johns Hopkins study that is claiming herd immunity by April, and if you have thoughts on that.
I don't know, maybe that's a modeling study.
Yeah, so I heard a little bit about it today. We'll be a little smarter about it tomorrow, but I think Fauci and others have criticized that pretty significantly and said that's not true. You'll have a lot of people who have been vaccinated or had the disease by April, but it'll be 40 or 50% of the population, and that is nowhere near herd immunity. Herd immunity occurs when you have 80 or 90%. So I think we would have to say, no, not true.
And I think we have to also really describe efficiently what we mean by herd immunity.
Yeah, I think actually that is the key.
So
Are you going to see fewer people getting sick because 40% of the population have been vaccinated or had it? Yes. The other thing is, and this is another one of Steve Steitz's logic times, and that may or may not be accurate, so take this for what it's worth. But the people who have had it tend to be people who didn't wear their masks. Now, I think that is true. But if you take the rest of the population and say, okay, the people who haven't worn masks, they've sort of gotten it. And now what you have is a lot of people who wear their masks, they're probably not going to get it. So it may feel like the rates drop a little bit, but your susceptibility as a population is still there until you've been vaccinated.
Yeah, I mean, I would ultimately love our definition of herd immunity, meaning, that it doesn't cause disease, so people aren't missing work and out of work for days at a time or weeks or 10 days and have those symptoms. But is it just, we're calling herd immunity because we can see the decrease in hospitalizations and deaths overall? It kind of just depends where we make that determination.
Kathy wants to know, should she stop taking medication if she's on RA or lupus drugs before she gets the COVID shot? She's worried that the medicine she's on might render the vaccine ineffective.
Yeah, that's a great question, Hawk. What do you think?
Some of those medicines have long half-lives, meaning they retain activity in your body for quite some time. I think depending on what it is, you really need to discuss with your healthcare provider that is giving those drugs, those prescriptions. I think it's a valid question. It's really hard to say. Some you can continue to take and you still will have vaccine efficacy, especially if you've gotten other vaccines while on it, including most of those types of patient populations will be getting influenza vaccine yearly. I don't know that they really stop taking those drugs. Or is it, your 5-year pneumococcal, your pneumonia virus vaccine? So just talk with your healthcare provider. But more than likely, if you are otherwise getting a typical influenza yearly vaccine, you probably won't have to stop those drugs.
Dr. Larson, when your patients are getting chemotherapy, do you tell them that they should stop chemotherapy so they can get the shot?
Absolutely not. Nope, we're not stopping any of their appropriate cancer treatment. So we can help them time it at a time that's appropriate before, after, those sorts of things. But it's not something where we want to delay or, have any downside from a cancer treatment standpoint in order to do that. So we have very safe ways that we can help patients time that. That takes into account the importance of getting the vaccine and staying safe from a COVID standpoint, but also is acknowledging the importance of that cancer care.
Well, and I think that's the key. I think what we've seen so far is even evidence in the transplant community that patients still have immunogenicity or immune response from the COVID vaccine, and those folks are really immunosuppressed.
Yeah.
Carol wants to know if we have an update on our long haulers clinic and when it might be open to patients that are not health system patients.
I don't know if they're not health system patients, if that's when that opens
It's not going to be before March 1st. But it is coming.
So that's like right around the corner, though.
I think we might have one of our touch base meetings this week about it. But it is coming. We fully do expect to and want to open it up to outside referrals.
I was looking at our schedule coming up. I think we have another session about the long haulers.
We do, March 8th.
There you go. So we'll know a lot then. So you have to watch every single day till then, and then we're going to have
I think it's in the first part of March is what we are pushing for. We are getting our protocols and our systems and our throughput, really, really down pat. So I think it's going to be in that first part of March when it will be opening up.
And if we do, we'll put something on before March 8th to let people know how to access.
Yeah, you bet.
Yeah, I know you got to be 12 weeks though, right?
Yeah.
Okay.
Because before 12 weeks, so we just think you have COVID-19. It's the folks who have it for all those symptoms longer. We want to go take a look.
Yeah.
Okay. And Jennifer wants to know if you would clarify, her perception is that we are not vaccinating patients 65 and older, or people in Johnson County 65 and older unless they are our patient. Why are we doing it that way?
So what we have done is Johnson County is different, and every county in Kansas has taken a little different approach. So we get vaccine supply from Johnson County. We don't get it ourselves currently. And so as a result, we work with Johnson County and we say, here's who we have the best access to try to vaccinate. And we have tens of thousands of patients who are over 65 in Johnson County. Advent Shining Mission has the same thing. Olathe has the same thing. Johnson County is out there vaccinating. So there are lots of different ways to be vaccinated in Johnson County. The way we've done it is to take those patients who we follow who are over 65 and have a Johnson County residence, and then we are able to vaccinate those. And we are doing them mostly out at our Indian Creek campus on the weekends. This last weekend we did, I don't know exactly how many we did. I think probably around 3,000. We'll find out the exact number. But that's the way we've been going about it. But that's because that's how we've worked with the county to determine how to do it. And now we have done it differently at other times. We've done first responders. We've had a more wide open thing. But at this time, the way we worked with Johnson County is to say we'll take those who are 65 years and older, live in Johnson County, are our patients. And we're happy to broaden that if our work with the county suggests we need to do that.
I'd say, before the distribution from the state to the county health departments, when we got our allocation, again, we were using our own patients because we have their data. We can understand how old they are. We can get in touch with them through my chart and their physician. But we did also vaccinate Missouri residents.
At that
That was a random. It continues to be a random.
It's a randomized approach, yeah. And the way that happened was because the only doses we've received directly are for our employees, and we have let's say 15,000 employees. But we would have a percentage who didn't take the vaccine. Mm-hmm. And so we would take that unused vaccine and open it up to our patients. And at that point, it was just a randomized list. Mm-hmm. We follow, I believe, 130,000 patients over the age of 65 at KU. They're from all over the area, whether it could be Missouri or Kansas. It could have been Wyandotte, Johnson, or it could have been one of the far western counties. It didn't matter. We were inviting those people in a randomized fashion. But that's because we had unused doses. We're past that. All those, when we talked about, we had our vaccine executive planning meeting on Friday, and I don't believe we have many unused doses at all. I think we've given every dose we had. For a while, we were keeping 200 or 300 back to make sure we had enough to get started on second doses. But I think as of Friday, we had used almost all of our doses. So.
Michael wants to know how well we think the vaccine is working for our employee base. He wonders if we test regularly. Do we know if it's going down in asymptomatic people? What do you know about the impact of the vaccine on our employees?
Well, it's done great. It's been, so our absenteeism from work, and absenteeism in bad terms, it makes you feel like you're whatever, but the truth is the people who have not been able to come to work, our number of employees who are out because of COVID-19 has dropped like a rock. I think we are down to like one or two. I mean, it's just so much
we had
fewer.
one Friday.
It's less than a handful.
And for a while, we'd have 60 or 70 people out or 100 people out on a given day. Yep. And now it's just doesn't happen. So it's been incredibly effective.
Time for one more question.
Okay.
Joyce wants to know, she called somewhere to get her mammogram scheduled, not here. And they told her, no, she'd had the vaccine. They said, no, you got to wait 4 weeks. And she just wants clarification about why they might have said that, if it's okay to get your mammogram and not delay it.
Mm-hmm. It's absolutely okay to come and get your mammogram. And so when we have patients who are coming in for any screening in our system, we certainly ask you if you have had a person who is positive, COVID positive, that you've had close contact with, or if you yourself have had any symptoms. And we require you to wait that time period in order to make sure you're not going to have any of those symptoms yourself, but other than that, we don't have any specific requirements for delays.
Yeah, the vaccine should not affect anything like that.
All right. Hey, tomorrow, KDHE Secretary Dr. Lee Norman joins us again. He's talking about what's going on to help fix vaccine reporting issues. And we've had some struggles around vaccine data, lots of things being done in the state of Kansas to help address that. And he's going to talk with us, and also why providers need to have help with the challenge, as future vaccine allocations are going to depend upon our reports. Final thoughts, Dr. Larson.
Anyone who is interested in IORT, this is a great option for your breast cancer treatment. It is also coming at the perfect time, as you said at the beginning, keeping people safe and giving them great cancer treatment and being mindful of their exposure. So from a cancer and a COVID standpoint, it's a great option for the right person.
Final thoughts today?
Yeah, I mean, I think we've all been happy with how cases, hospitalizations, and deaths have been going, especially locally. We need to keep up our vigilance and doing that thing. It's going to be nicer, so people will be getting out more. You know, we do think some of this cold weather with people just kind of staying huddled in their own bubble at home has had an impact. How small, how big, we don't know, but I think it's been good for that. We just hopefully we can keep the number of daily cases and rolling 7-day average down and hospitalizations down. Vaccine will be getting out there. We know that the CDC and ACIP will be meeting soon for the Johnson & Johnson EUA, and hopefully they'll find the data good and acceptable, and that'll be one more piece of supply that we can get in to get vaccination to everybody out there.
So today we pass a remarkable milestone in the United States, but it's not a good milestone. 500,000 deaths. That is that's a tough statistic, right? Fear. That question early on in this broadcast about fear, isolation, depression, anxiety. Don't let fear drive your choices. We've proven over and over again every single day, right here at KU, as has every hospital and healthcare provider across the country, been able to demonstrate that good infection control technique keeps you safe. Before the vaccine arrived, we didn't have employees getting sick on COVID wards, yet they're taking care of patients with COVID positive of symptoms and COVID positive disease. Why did they not get sick? Because the rules of infection control can beat fear. If you follow those rules, wear your mask, keep your distance, wash your hands, do the things you hear us preach about every day, you can stay safe. And in the meantime, real hope, real science, real answers are on the way. Today we have a video. We're going to show you a little bit about the side effect about mammograms. And we've talked a little bit about that already today. And from people who've had COVID-19 vaccine. Two of our best and brightest cancer specialists tell you everything you need to know in this video, including why it's safe and necessary to get your mammogram and your shot. Remember, don't let fear make your decision. Don't stay away from real help and real medicine and real science because of fear. Fear is something we have to understand and know, but don't let it drive your decisions. Let infection control take care of you because we've done it every day right here in this health system. We can keep you safe. Get your mammogram. Get your medical care. Don't let fear make you ill. We'll see you tomorrow.
About 10% of patients will have lymphadenopathy, which is just meaning swelling of the lymph nodes in that armpit of the site that the injection is given. And after the second, they saw as much as 16%. So with that, we have to pay attention because we also know that we can get enlarged lymph nodes with breast cancer diagnosis.
We have observed a small percentage of our patients presenting with enlarged lymph nodes following the vaccine. This is a small percentage of patients. This is a benign finding, nothing to be alarmed about. This will resolve. The important thing to note is the vaccine does not cause abnormalities in the breast. It's also important to note that having the COVID vaccine does not limit our ability to find breast cancer on imaging.
The bottom line is, despite the fact that we're having this, we do not want women to continue to delay getting their mammograms, because if we think back from this last year, we've had a 50% decrease in diagnosis and women are getting diagnosed at more advanced stages. So I don't want this to be an excuse for women to not get their mammogram. We are absolutely recommending that if you have a known diagnosis of breast cancer, we want you to get it in the opposite arm. It has seen on an average of about 12 to 14 days is when a lot of it is starting to resolve. It has been as long as 4 to 6 weeks in some.
From an imaging perspective, we can often tell if lymph nodes are reactive simply to a vaccine as compared to due to breast cancer. And if the breast is normal and the lymph nodes have a very specific appearance on ultrasound, we're pretty good in breast imaging about being able to identify these as due to the vaccine and not breast cancer.